I'm Megan Clapp, and for my capstone presentation project for the year, I chose to do it on non-opioid pain management, specifically in the post-operative setting. I'm going to go over my PowerPoint with you guys just to kind of educate you on the use of narcotics and opioids and what alternatives there are. The point of this, hopefully you will be able to understand the statistics of opioid use and abuse, the alternatives of opioid medication for pain management, and recommended guidelines for practice. So post-op pain management helps facilitate healing. It is usually the first 3 to 5 days are the most important. That's when you will experience the most pain after surgery. Physicians usually prescribe opioids and non-opioids, non-pharmacologic relief measures. So the risk of opioids, you'll have an increased sedation level, your respiratory drive goes down, you risk the chances of increased constipation because of the opioid use, and also you are not doing early ambulation after surgery, which helps promote the healing as well. And then also the possibility of addiction, abuse, and possibly overdose. There is 21 to 29% prescribed opioids are abused. There is approximately 1.7 million Americans do develop a opioid misuse disorder, and in 2019 there was approximately 50,000 overdoses caused by opioids. My question for the capstone project is, in the postoperative setting, how do non-opioid pain medications compare with traditional opioid medications, and how do they affect pain management within the first 3 days of surgery? These are the literature that I used for my project, and how I went about limiters and decided what were the appropriate references to use for my project. There are a couple alternatives. I'm going to go over them in the next few slides. Pharmacologic and non-pharmacologic alternatives for pain management. The first one is medications, acetaminophen, such as Tylenol, NSAIDs, which are non-steroidal anti-inflammatory drugs, such as ibuprofen, Advil, Aleve, those kinds of things. There is gabapentinoids, such as Neurontin and Lyrica, and then medications such as ketamine, nitrous oxide, and other non-opioid pain medications. Anesthetics are also an option that you can use. They're neuraxial, which are epidurals, spinals, and those help numb everything. And then there are also peripheral nerve blocks, which are injected peripherally. They can either be single shot or continuous drug that is infused. And a lot of the time it also has a steroid in there as well to help with the pain control. And then IV locals such as lidocaine infusions can also help. A couple recommended guidelines are: evaluation is absolutely necessary when treating a patient. Number one priority is stabilization of the patient before pain medication and pain management is taken into consideration. It is important to assess post-operatively at scheduled intervals. That way you know that your patient is being taken care of appropriately. Education is also very important to set realistic expectations for pain management and what they will be feeling. It is individualized also. It depends on the patient, the operation, in certain circumstances, what will be the most appropriate choice for the patient. You must talk about advantages and disadvantages with the patient and make sure that the advantages definitely outweigh the disadvantages in a certain thing. And discharge planning is important as well. Discharge starts at admission. It's important to the patient to know what to expect when they are planning on going home. These are more of the guidelines that you can read over. One of my examples that I did was a colorectal study. It was for a group of 50, aged 42 to 83 years old. The group was split into two, those that chose opioids and those that chose non-opioids for their intraoperative pain management. They all had to have the same type of cancer, no lymph node involvement, and they were all getting the same surgery, which was a partial colectomy. The non-opioid got preoperatively Tylenol and Lyrica, and then intraoperatively got non-opioid epidurals, and same with pain management afterwards, non-opioid. They made the decision, they knew what they were getting themselves into in the study. The pain level were assessed every 8 hours post-op day 1, and then daily after that. Vital signs such as heart rate, blood pressure, and respiratory rate, all of that was done every 2 hours, then every 8 hours, and then 3 times a day post-op until they were discharged. And it was found for this study that pain was controlled more with the non-opioid pain management, and it led to early discharge. The people that were getting the opioid pain management ended up having longer hospital stays. So it just shows that it does work, and it is something that we should try to push more to increase patient satisfaction, because they're not in the hospital as long, as well as patient outcomes because they're not having that decreased respiratory drive. They're getting up and walking. They're just overall healing better than those with opioids, and it will help prevent the possibility of overprescribing, overuse, misuse, and the possibility of the overdose for these patients. So my references that were used, I do have a quick 8-question quiz that I will attach to this video that you can answer, just kind of reiterating, making sure you understood all of the information, and then also just telling me how I did as a presenter too. So thank you for listening to my project on non-opioid pain management in the post-op area.